File 4500 and Senate File 4476. Both of those will be laid on the table. Let me begin by bringing Senate File 4500 before the body. I just want to explain to you what the intended path of this language will be. First of all, it should be the conduit for a partnership between the institutions that are on this call, the University of Minnesota and Mayo Clinic, and other stakeholders as they engage. I will be working with the House, the Governor's Office, and the Minnesota Department of Health to have a broad testing strategy. There have been a number of conversations, and I think we'll hear more about what an aspirational or perhaps ideal testing strategy would be. And then we'll start to get language on paper, and this would be the vehicle by which we would move it to finance. We'll need a stop in rules, and then to the floor would be the most circuitous route. As we know, some COVID things have been expedited, but as soon as the language is available, we would make it available to this committee. I don't want to move a vehicle bill out. I think that you are the most engaged experts in this area, and I really want you to have a good look at the language before we move it out. And then Senator Nelson has Senate File 4476. I'll ask her to move that later. Very important to talk about what the Mayo Clinic is doing as it relates to that language. But first on our agenda is Dr. Jacob Tolar from the University of Minnesota. We're going to have him speak for a few minutes and then have some questions. I see he's taken himself off mute. Thank you. We are missing your video, Dr. Tolar. If you want to proceed without video, that is fine with me, but proceed as you'd like.
Thank you, Madam Chair and members of the committee. I am appropriately dressed. I have a tie and jacket. You know, this is not that I'm hiding some kind of a t-shirt and new facial hair like almost everybody else now. Thank you for having me with you today. My name is Jacob Tolar. I serve as a Dean of Medical School, Vice President for Clinical Affairs, and the Physician-in-Chief for the University of Minnesota. I have trained as a bone marrow transplant physician. This is my day job. I have a large lab that works in molecular biology, and my PhD from the University of Minnesota is in molecular biology and virology. I am stating this only to underscore that, you know, I have a very much of a clinical basic science as well as institutional interest in your leadership and your support. Now, I thank you again for the opportunity of having me and others, you know, around the table today, because I delight in the partnership with Mayo Clinic and Hennepin County Medical Center and all the other good-willing systems and people in the state. And I am tremendously grateful for where we are at in the state of Minnesota. I've lived here for 30 years now, and I'm very loyal to the state and to its institutions and to Minnesotans in general. And we are, by my counts this morning, we are still at the very bottom of the states in the union for the number of cases per 100,000, next to Puerto Rico, and we are among the 8 states with the lowest death rate from COVID-19 in the continental United States. Now, the leadership that you provide is truly catalytic, and what it really surfaces, in my opinion, is that there have been many plagues in the history, of course, and what seems to be happening is that every single one of them is taking people by surprise. It should not be that way. We have had 3 coronavirus epidemics in this century alone. In 2002, that was the MERS. Then 2012 was the next one, and then this one. So this is something that's coming pretty frequently, and it is not as some think, you know, the disaster that came out of the blue. This is an ecological man-made disaster, and why this is important is that the confidence we have in science plays out greatly, especially when we get to the bottom of how we deal with the epidemic, and the antibody and molecular testing are at the fulcrum of this. Mr. Huff, was very good last time we met on a similar platform, describing the metaphor of driving down the hill without the headlights, and how the testing provides the headlights. That's how epidemics of this kind stop. What has happened in this year at the University of Minnesota was the larger view of the whole epidemic, and we started to prepare very early on, and started with the COVID-19 hospital. This is where my partner, James Herford, at the Fairview Health System is irreplaceable, because we have coordinated to get our clinicians and nurses and all the personnel into one location with the patients that are COVID-19 positive. And that is, what typically leads to a isolation of the context and mapping out the context, in that way. The second thing that we have done is we have designed 3 different treatments that are spanning the continuum of the COVID-19 disease, from the contacts like health care workers or household contact that have been exposed but not yet sick, to people who are COVID-19 positive but do not have serious symptoms, to the ones that have profoundly significant disease that's a multisystemic. And I can tell you, this is very different from anything any of us have seen from this perspective of the lung pathology alone. There's a clotting component to it. There's a renal failure component to this. There is a brain hallucinations and delirium component to it. This is different than we have seen before. It is important that knowing that pathophysiology and knowing the treatment leads to a personal advances. The personal advance that you may have seen in the Star Tribune on Sunday was a story of the 38-year-old marathon runner, Ironman trained person, who got very sick and had to be put on the highest level of support that we know how to provide, which is a heart and lung machine called ECMO. And he was very close to dying. And it is incredible, I think, to be able to report that because of the clinical care he received, he actually is at home now, and together with his young family is getting along with his life. The third prong in this 5-prong approach was the equipment. So we realized very early on that the way the personal protective equipment has been rationed and hoarded at some times will not be able to support the healthcare workers and the platforms that we have designed for our patients and for Minnesotans. So we teamed up with the College of Science and Engineering and College of Design at the university, and several of the companies in the state, and developed our own independent source of the swabs and ventilators, low-cost ventilators, and so forth. And then, let's go to the testing itself. So it started from our colleagues in veterinary medicine, along with medical school, putting together a picture, a crystallography picture of how the interaction between the spike protein of the virus and the receptor on the human lung cells, what it looks like. From that, we grabbed that and designed a way of getting the specific protein, the specific antibody that the SARS-2, the COVID-19 virus reacts to. And from that, we have exported it into the realm of the clinical testing, and that's where it is right now. The advantage of that is that we do not have to rely on outside sources, because we have between 100,000 and 200,000 of that protein dose that we need to use for the testing that looks into blood of somebody and can tell whether there is an antibody present as a result of the past infection. Sometimes that infection may have been unnoticed, asymptomatic infection. And in this way, we can isolate the people who are susceptible to the infection from those that are most likely protected from the infection by virtue of having this. And if they are outside of the first 12 or 15 days of the infection, chances are that, based on the analogy with the previous coronavirus infection, that the antibodies that are generated, just almost everybody who has an immune system will create the antibodies. And it's quite likely, even though we do not know for certain, that these antibodies are what we call neutralizing, which is that they take the virus or the infected cells out of the system. So along with Mayo Clinic, which has been incredible in its advance of the serology testing, we are poised to be able to, in collaboration with Mayo and with others, to really provide for the state what it takes to get people tested. It is very important that the serology alone is not sufficient. It is important, in my opinion, to deliver a paired test, which is the molecular test, along with the serology test, because only with, in comparison of the two, one can say whether there is a protective immunity or immunity, and whether that person is shedding the virus or not. And obviously the constellation that would be most favorable in those that we would say you can go back to work, you can go back to the operating room, you can be outside, would be the constellation when the antibody test is positive and the PCR test, the molecular test, is negative. So with that, I'll stop here and say that the Minnesota state has been in very good position. And we owe it, I think, to the state to, symbolically and morally and scientifically be the leaders and take responsibility for the sickness of Minnesotans. And the disciplined and direct action is really where we are headed. Thank you, Madam Chair.
Thank you, Dr. Toller. We have about 5 minutes for member questions, and then we'll move on to the Mayo Clinic and Hennepin County Medical Center. So I do see Senator Kiffmeyer.
Thank you, Madam Chair. Appreciate the opportunity. This should be a rather brief question. Question is, have you considered doing, like I've read about other countries or around the country, a test pool, a known group that has had COVID? Could be a variety of basis of these that could be done to extrapolate possibly those that may have been asymptomatic but have the antibodies. So you kind of have a sense of that. Some of those test pools, is that part of your consideration as well?
Dr. Toller?
Madam Chair, Senator Kiffmeyer, this is an excellent question. We have several, we have not done this ourselves outside of the testing for the antibody, where we set up what we call sensitivity and specificity of the testing by testing people that we know are COVID-19 positive and had the disease, and those that we know they don't. There are, however, at least 3 reference ranges that I know about that are quite helpful. One comes out of Stanford, where they tested antibodies in about 3,300 subjects, and realized that there are about 3% of the people that actually do have the antibodies, and that would be about 85 times higher than the count of the so-called COVID-19 positive. So your question is absolutely perfect, because yes, we underestimate, we undermeasure, those, in the population by the testing that's done at this time. The second example is Iceland. Iceland, by virtue of being, a little, isolated, being an island, and having a tremendously solid molecular biology testing, and, for the genome testing, and sort of population that can be grasped, they have done an incredible, job, I think, in testing multitude of people, and found the same thing, that we underestimate, the people. And I think that the best guess, because this is all it is about 25% of people that are positive and can shed the virus may have no symptoms at all. Madam Chair.
So, Madam Chair, if I can
just... Senator Kiffmeyer.
Thank you. Would you mind sending to the committee the Stanford and Iceland links to those studies in some way so we can take a look at that?
Madam Chair, Senator Kiffmeyer, yes, I will.
Thank you so
Dr.
much.
Toller, and I'll have staff follow up to make sure that we close that loop. Next on my list is Senator Jensen.
Thank you, Madam Chair, and thank you, Dr. Toller, for joining us. The question I have is, there are reports that there's probably more than 50 specific serology tests that have come in from different manufacturers from around the world that have the FDA has approved, many of them coming from China, which for me is not necessarily problematic. But my question is always, how many false negatives and how many false positives are we getting? And is there any way that clinics, smaller clinics, could send one or two of these testing things to the university to cross-match so that you could run them on controls and make certain that let's say we have a moderate-sized clinic in St. Cloud, and they would like to know that the test they're using, could they send it to you? Could you help us in that regard?
Madam
Toller?
Chair, Senator Jensen, thank you. Very, very good question. And the answer is yes. We will coordinate again with Mayo Clinic because we are going to hopefully do this in collaboration, but absolutely there should be a unified approach to this. I want to comment quickly on your comment of the false positive and false negative. There are certainly going to be false negative and false positives. And that's why on the serology side, we have created not only testing for the total immunoglobulin, but also for the titer that we can test those that have been tested positive and then refine as a titer, as a number of times we have to dilute and measure, quantify in a way, that particular testing. We have been given a gift of that California study, because in Santa Clara there have been 4.6 baseline prevalence noted, and in their testing, and I don't know exactly where they gotten their testing, there has been about half of these tests have been false positive. From ours, that we are looking at, this is nowhere close to that. Madam Chair.
Thank you, Dr. Toller. Senator Jensen, anything further?
Yes, thank you, Madam Chair. Appreciate it. Thank you. In regards to the Clara City study of the 3,300 people that indicated 50 to 85 people with the disease for every confirmed test, do you think when you said that there was that many false positives, did they calculate that in and correct their data?
Dr. Toller?
Madam Chair, Senator Jensen, I don't know. I don't know what the follow-up was, but I'm happy. I have many colleagues and friends at Stanford. I'm happy to follow up and deliver that information back along with what Senator Kiffmeyer asked for.
And then the last question would be,
Senator Jensen.
Thank you, Madam Chair. Are you seeing the IgM antibody form somewhere between 7 and 14 days? And then around the 14th day is when you're starting to see the more mature IgG developing?
Dr. Toller?
Senator Jensen, this is wonderful to have a partner immunologist on the other side. Yes. So yes, we can obviously get the classes, of the immunoglobulin as well. And we would expect this to have the usual, first, the rise of the antibodies and then the secondary response and the memory antibody as well. Yes, Madam Chair.
Thank you. Thank you so much, Dr. Toller. Let's move on to Dr. William Maurice and Dr. Matthew Binnicker from the Mayo Clinic. We have about 10 minutes for their presentation and then follow-up questions. Welcome to the committee. And who are we going to have go first?
I think I'll go ahead and set the stage. So first of all, Madam Chair, committee members, thank you for the opportunity to meet with you today and to talk. My name is Bill Maurice. I've been at Mayo Clinic since 1987, where I came from medical school, I think as one of your fellow committee members as well. My PhD is actually in immunology, and I'm a hematopathologist. So we have kind of a blood immunology bent to the first couple of presentations here. My position is somewhat unique in that I'm both the academic chair for the Department of Laboratory Medicine and Pathology at Mayo Clinic, and also serve as the president of Mayo Clinic Labs, which of course is a national reference laboratory which uses the labs in Mayo Clinic here in Rochester to provide testing for patients around the country. As it was in that role that actually I was called to be part of the group that met with the Pence team early, about 6 weeks ago, almost 7 weeks, I guess tomorrow, with the CEOs of Quest, LabCorp, and others about how Mayo Clinic could be part of the national response. That is important because I think it paints. Allows us to have a very complementary role to the university, and that of course was really to drive partnerships between the manufacturers of the testing kits and reagents and machines with the laboratories that can provide at-scale testing for the country. So we did with Dr. Binnicker, who's joining me. I have that privilege. He's the chair of practice for our department, also an expert virologist. Very convenient. So very early on, Dr. Binnicker and I and other leaders in our department decided to develop a molecular test at Mayo Clinic for the SARS-CoV-2 virus. That was in early February, just based on our own concerns about how this disease was starting to spread across China. That put us in a good position as the country realized the need for testing to stand that testing up quickly. But we have, in addition to our own tests that we've developed within our institution, then worked with industry partners like Roche and others to scale up molecular and now serologic testing for the state Mayo Clinic in the country. So we've been involved very early on in how to make that capacity available. The other thing is that we have also really put a focus on innovation as well, just like the university. Of course, the university has such great research and some great people there, and has done wonderful things with the serology. We have focused on some other areas of strength for Mayo in terms of translational innovation around some of the other tools that would be needed to fight COVID, including neutralizing antibody studies and also looking at data and how to use data, how to manage patients with severe COVID disease, which Dr. Tolar spoke to as well. So those have been some of the things that we continue to work on as in the institution and in collaboration with actually the Destination Medical Center using our Advanced Diagnostics Lab, which was funded as part of that. So continuing to build on those innovation streams as well. I asked Dr. Binnicker to comment. He's very much an expert in terms of Mayo Clinic's response to the virus itself and our current testing and how our testing capacity has grown. So I'll kind of yield the floor to you, Dr. Binnicker, to kind of speak to the committee to some of that. And thank you, Madam Chairman.
Thank you. Welcome, Dr. Binnicker.
Yeah, thanks, Madam Chair and committee members. Glad to have the opportunity to comment on our testing response. We've been performing PCR molecular testing for SARS-CoV-2 since March 12th and just surpassed the 21,000 test mark here in the Rochester and Southeast Minnesota area. It's likely that the number of total Minnesotans that we've tested over the past 3 to 4 weeks is double that with the volumes of tests that we've received in from around the state. We've also just brought up serologic testing in the past 7 to 10 days and have large capacity for antibody testing. I wanted to mention that I completely agree with Dr. Toller's comment about the combined use of PCR and serologic testing. I think that when those two tests are used in combination, we can get a much better appreciation, at least currently, at this stage in the pandemic, for where a patient is at in terms of their exposure. We are employing both methods and trying to put individuals into different risk tiers. So, in other words, a patient who would test positive by PCR and negative by the antibody test, we would consider to be a high risk individual for ongoing transmission of the virus. An individual who would test positive by PCR and positive by serology is likely in what we call a window period of the virus declining and the antibodies increasing. So we would consider them to be at moderate risk, and we may enact some further precautions for an individual like that. And then the last tier are those patients who would test negative by PCR and positive by antibody. As Dr. Toller mentioned, those are the individuals who appear to have antibodies and not virus, and would be our lowest risk category. What we don't know yet is how long the antibodies persist and whether they provide strong immunity against the virus. I think we have some data because of our convalescent plasma therapies that there is neutralizing effect of these antibodies, which is very good news. But we still have a lot to learn in terms of how long an immunity to this virus lasts. Is it a month? Is it 6 months? Is it a year, or is it the lifetime? My guess is it's probably a month, or sorry, a year or less. Uh, uh, in comparison to what we know from other coronaviruses. But again, we'll learn a lot over the course of the next 6 to 12 months as we are doing more antibody testing and getting re-exposure data from these patients. So I'll stop there, Madam Chair, and be happy to answer any questions.
Thank you. Members, questions for Dr. Maurice, Dr. Binnicker? Dr. Binnicker, this is the first I've heard of immunity lasting less than a year. Is that because the virus would mutate and therefore an established immune system, an immune response wouldn't be effective? Or would this be because the particular immune response to this virus is only going to last a year? The human body just doesn't behave any differently.
Yeah, it's a really good question, Madam Chair. And I would say that it could be either of those scenarios. For influenza, we have to get our annual influenza vaccinations because the virus that we'll encounter in 12 months is not the same as the virus that could be circulating currently. So that's why the annual vaccinations are required. But I think there are also scenarios in infectious diseases, in particular viral infections, that we know that the immunity does not last as long as others. Typically, our vaccines for measles, mumps, varicella can last in the range of decades, but natural infection to some viruses does not lead to a long-standing immune response in all cases. But again, we'll, I think, learn more over the coming year exactly what that immunity looks like. Madam Chair, thank you.
Thank you. And on my list, I have Senator Nelson and Senator Kiffmeyer. And then Senator Jensen just raised his hand. So members, remember to raise your hand, or you can chat with Ms. Strand and she will add you to my list. Senator Nelson.
Thank you, Madam Chair. And thank you for all of our doctors and those who are leading on the front lines. I just had a couple questions. This testing discussion is so critically important, and you touched on how we might be able to use both the diagnostic molecular test as well as the serologic test to determine risk factors as far as someone perhaps going back to work, for example. And I wanted to congratulate Mayo on its lead in the National Convalescent Plasma Therapy. And I'm wondering, though, one of the things that we all seem to realize how important the testing is. But one of the issues that I've been learning about is that there is a shortage on the reagents for some of the testing or the vaccines. And I'm wondering if both the Mayo physicians might be able to comment on Mayo's position there, and also Dr. Tolar. Does the U have needed resources and reagents to move quickly in scaling up our testing capabilities?
And I will let either Dr. Maurice or Dr. Binnicker.
Sure, Madam Chair, I'll take the lead on responding and pitch it over to my teammate, Dr. Binnicker here. I'd like to start by just reiterating Dr. Tolar's point. I believe in the state of Minnesota, and I believe that actually we are positioned as a state to help answer some questions for the country in terms of how to manage COVID going forward. The questions around immunity and what it means are going to be very critical, not only for driving testing, but also even public policy around how people are safe to move and congregate in those things. And I think that between the University of Minnesota, Hennepin, and the population it serves, because I think we have to think of the underserved and their ability to do some of the things that we know are mitigating factors like social distancing. I think we have a real opportunity to lead in the country in answering some of these questions and including the best way to use therapies. We have been engaged. The supply chain issues are real. Dr. Binnicker has really been our leader on that and helping to manage that on a really almost a day-by-day basis as this has evolved. So I think Dr. Binnicker, if you could answer that question. Thank you, Madam Chair.
Dr. Binnicker.
Yeah, thank you, Madam Chair and committee members. So there were definitely supply chain issues and continue to be challenges. 3 weeks ago, we were very concerned about availability of test reagents, equipment, and even supplies to collect patients. So the swabs, the transport media that's required to get a swab from the collection site to the laboratory. There was indication from clinics around the state that they were running out of those necessary supplies. Today, we are in a better spot with the test reagents than we were several weeks ago. And I think that's a large result of more diagnostic companies bringing their tests to market so that there's not such a high supply and demand issue. In other words, 3 weeks ago, many of the labs in the country were racing towards just a few options, and that put a real crunch on the available supplies. Now that there are many more options, it's spread out the demand and allowed labs to get access to necessary reagents. Will that continue to be the case? I hope so. I think as we start to see more testing in the asymptomatic population, so workers, citizens trying to get back to business, that may put a further demand on testing supplies. So we'll have to keep a close eye on that. But I think we're in a better position today than we were 2 to 3 weeks ago. Madam Chair, I'll turn it back over to you.
Thank you very much. And now Senator Kiffmeyer, you
Oh,
have a
Dr.
question.
Toller, Madam Chair, I was wondering
Oh.
how the university's prepared as well.
And Dr. Toller hadn't taken his microphone off mute, but if he'd like to speak, I see he's off mute. Yes.
Madam Chair, Senator Nelson, thank you for the question. I tip my hat to my friends and colleagues at the Mayo Clinic, excellent responses. I'm gonna add to this that as a molecular biologist, we build these things. You see, we can deconstruct a kit into its components and the standard operating procedure steps, and we can redesign it, and we can this way earn a freedom to adapt to the shortages in the supply chain or otherwise. That's exactly what we have done in the serology. That's exactly what we have done in the molecular testing. And if we didn't have swabs, we just made them. And if we didn't have the medium, we just made it. If we realized, that the extraction step of the nucleic acid, of the blueprint of the virus, is not necessary in getting the polymerase chain reaction going, and then we can skip a step. So we are sort of anti-fragile in a way, because we can actually take these little bits and in a modular fashion put them together in the most rigorous and in most disciplined and validated way. Madam Chair.
Thank you very much.
Madam Chair, if I could just add one comment to that. And
Dr. Maurice,
totally agree with everything Dr. Tolar just said. I think one of the reasons that both all of us that are here representing the medical community are very much want to support this work is that we recognize also that the resources available at the University of Minnesota and at Mayo Clinic are not going to be available in Crookston or in some of the other communities that are smaller, that would not have the same kind of plasticity, if you will, of resources. And so creating some kind of network that allows every citizen in the state to get access to the testing they need by being confident that when they go to the doctor and they need the test, they can get it. I think that's a really paramount importance to all of us here that are joining you today.
Thank you. And next, Senator Kiffmeyer, and then Senator Jensen. I'm not seeing other hands. Please proceed, Senator Kiffmeyer.
Thank you, Madam Chair. I think the first thing is just a comment on hearing from these three doctors, Toller, Binnicker, and Maurice, at how proud I am of our state of Minnesota. and how grateful I am for the brain trust that we have there and their innovation, being plasticity, other things all included. So I just like, oh, thank you, Lord. I'm so grateful. The question that first of all, my constituents sometimes they hear about the great things Mayo's doing in University of Minnesota, some of their involvement nationally. They get concerned about are we going to be shortchanged? They kind of imply in Minnesota while you're busy helping others. I think that's not the case, but I want to assure that. Then I have two other questions. One is we hear sometimes about the reinfections as if somehow you can maybe have a relapse. I get that. If you could address that issue. Then the other one, I just read about the FDA approved LabCorp to do private testing direct to consumer. Is that even valid or worth it? I suspect there's going to be others, and especially people in the private area who may say, I can't get it from this place, I'll go order my own. I'm not sure if they're going to be fraudulent, valid. If you could just respond to those items.
So, and Senator Kiffmeyer, who were you directing the questions to? We have Dr. Maurice.
Anybody who would like to respond.
Well, I suppose I will, Madam Chair, I'll take the lead on the first question about Minnesota and our commitment to the state. I came here as a 21-year-old. I don't mean to be corny, but I love the state. My family lives here. My adult children live in the Twin Cities. I know Dr. Binnicker also is raising his family here. I mean, most important, I think if there are some silver linings to this, and it's one of them is our ability to, number one, work with our colleagues across the state for the benefit of the state and really prioritize and let everyone in the state benefit from having great institutions like Mayo and the University of Minnesota and Hennepin County Medical Center in it. So that's our commitment. That's my personal commitment to every committee member here. In terms of the reinfection, the quality issues were also, I think, spoken to by Dr. Jensen or by Senator Jensen, excuse me, a little bit before. And just in terms of, we definitely need to ensure the quality of the testing that's being provided is answering the questions that patients and citizens of the state need. I think that's the other advantage of working collaboratively is we can help make sure that the quality is consistent where the testing is performed in the state. And I can let Dr. Binnicker speak more to the reinfection. I mean, that's really his realm of expertise. And so what we know and what we don't know about the infection itself.
Very good. Senator Kiffmeyer, anything further?
I think they referred to, if any of the other two doctors, Toller or elsewise, want to respond to the reinfection
Yes, ma'am.
issue.
Madam Chair, Senator
Toller.
Kiffmeyer, I don't want to, Dr. Binnicker, if you want to go ahead with me, that's fine too. I'm just going to say that the reinfection is a possibility. The best study that I know about is the South Korea Center for Disease Control and Prevention. They had a report that had 91 patients who had been infected with COVID-19, and then they tested negative, and then later on tested positive again. So one interpretation is reinfection, but more likely interpretation, in my opinion, is that these patients were false negative in the middle of an ongoing infection and tested, in that window. So I think it's much less likely than has been portrayed by the CDC in Korea. Madam Chair.
Okay, thank you. And I'm going to move on to Senator Jensen, then Senator Hayden, and then we'll move to HCMC. So Senator Jensen, please.
Thank you, Madam Chair. And gentlemen, thank you very much, all three of you. I'm going to make a comment, and then I have a question regarding the SARS-CoV-1 in 2003. First off, we're certainly learning a lot on the way, and I do think that in Minnesota we're so fortunate to have both the university and Mayo, and it seems to me that one of the initiatives we're going to have to take up relatively quickly once we get on the correct side of this pandemic is to see if we can't in Minnesota lead in a very strong way so that when it comes to the next epidemic, that we have a crackerjack, if you will, laboratory that can combine the university and the Mayo assets to put together that test ever so quickly. I mean, January 10th, we had the sequencing done of the adenosine bases. We knew that. And so that was nice, but we still struggled to get the testing that we want. And obviously, everybody's frustrated. So I'm hopeful that the legislature next year can, bipartisan manner, go ahead and somehow put that together. We have to fund that. We have to let you folks have what you need to have in order to lead. So thank you. The question is this. I've read in several journal articles that after 2002 and 2003, when we monitored populations, and it wasn't that large a population that actually had the SARS-CoV-1, but we did monitor antibody prevalence going forward. And the studies I read indicated that there was good evidence that with that antibody, there was IgG present as much as 5 and 6 years after the infection in 2002 and 3. And so to Senator Benson's earlier question, that this was the first information we'd really been hearing as a committee about potentially the antibody protection being short-lived. Could you comment on what we saw with SARS-CoV-1 and how you might extrapolate the findings in that situation to this situation?
I see Dr. Maurice is unmuted, so let's go to Dr. Maurice.
Well, actually, I was just gonna, this would be Dr. Binniker's. I could respond, but this
Okay.
really is a Dr. Binniker's wheelhouse. So if he could respond, that would be great.
Sure.
Dr. Binniker.
Yep. Thanks, Madam Chair. Happy to respond. So, as Senator Jensen correctly pointed out, in some seroprevalence studies of both SARS-CoV-1 and MERS, there has been evidence of antibody persisting for 3 to 5 years in some patients. And I would say that we may be able to infer from those coronaviruses that the same will occur with SARS-CoV-2, but we just don't know yet. We do know that this virus is different in terms of its spread and pathogenicity compared to those other viruses. So it's really too early to know what the immunity will look like. Is it relatively short-lived, or is it longer? We're definitely hoping for longer-term immunity, but we won't know for the next several years.
Thank you. And Senator Hayden.
Good. Well, thank you, Madam Chair, and fascinating listening to all of these extremely smart, brilliant, intelligent doctors and others on the line. I'm fascinated with the conversation. My question, I know we need to get to HMC and the bills. Can you, any of the doctors, speak a little bit to this issue of its prevalence in communities of color? I think I probably know the answer, but can you talk a little bit about what we've been hearing in other states and even countries that indigenous communities and communities of color are particularly susceptible to the lethal nature of this disease?
Sure.
Thank you,
Madam
Dr.
Chairman,
Maurice.
yeah, I can take the lead. Sorry if I broke protocol there. Sorry about that. My apologies. First, I want to address certainly Senator Hayden's question. Also, to kind of go back to Senator Jensen's point, I think Dr. Tolar also made this point earlier. One of the most disappointing things about this is that each state and each country is kind of reinventing the wheel as if they didn't see it coming. We definitely have to come out of this with a much better system to manage this as a state. And also during this is actually how do we collect the data so we can make decisions more quickly as a state as opposed to institution by institution. And to your point, Senator Hayden, understand how this is impacting different parts of our community. I think there is now very strong evidence showing that when the virus is, how it's playing out in different socioeconomic groups is different across the globe, in part because of the difficulties in social distancing and some of the other measures which we know are effective. In some communities, that's very difficult to accomplish where there's cohabitation. There's different access to testing to even know how much disease prevalence there is in some of these communities. And last but not least is the fact that in some of these communities, some of the underlying health conditions that make someone more vulnerable to getting severe COVID disease are more prevalent. I think this is important, very important, that we make sure whatever testing we do, we have enough of it in those groups across the state that they have access to the testing. And also, Dr. Tolar alluded to, we'll see probably a continuous cycle of interventions that can help prevent patients from really getting into that deep COVID disease trap, whether it's convalescent antisera, which we have now. There's a number of antivirals which are being developed and other monoclonal therapies and eventually a vaccine. We might have to really understand how to get those to the communities that might need it most, like the communities that are socioeconomically disadvantaged might have a greater need for some of those therapies because they will not be able to social distance and other things. And I think that's another reason why these discussions are so important at this committee. Thank you, Madam Chair.
Thank you
Good.
very much.
And
Senator
thank you.
Hayden?
Thank you, Madam Chair. Well, I think you led right into what my other comment was going to be, was just that as we move forward to figure out, how to, our collection of very phenomenal healthcare systems to ensure that as we test and as we do all of the great research that we have a wide swath of folks that are there to ensure that we get the penetration in those communities that seem to be the ones that are having the most trouble with the disease. So thank you, Madam Chair. I think that doctor answered my question perfectly.
Thank you, Senator Hayden. And as we move on to Dr. Hootie from Hennepin County Medical Center, obviously as part of your presentation, if you want to take on any of the questions that have been addressed so far, we'd love to hear. HCMC's a very different kind of hospital than Mayo Clinic, and your experience will help inform this committee's decisions about how we approach testing. So please proceed.
Thank you, Madam Chair. So, Madam Chair, members of the committee, my name is Dan Hootie. I'm the Interim Chief Medical Officer for Hennepin Healthcare System. Hennepin Healthcare is an integrated system of care that includes a nationally recognized Level 1 trauma center and a clinic system with primary care clinics located across Hennepin County. Almost half of our patient population qualifies for Medicaid for their health care, and 1 in 5 of our primary care patients are experiencing housing instability. 60% of our patient population is non-white, and 20% prefer a language other than English. Many are particularly vulnerable to chronic health issues, food insecurity, and frequent transportation challenges. Our 7,000 employees proudly provide care for patients from all over Minnesota. Much like the other healthcare systems testifying here today, we at Hennepin are on the front lines of the COVID-19 pandemic. We're treating patients with COVID-19. We have healthcare workers who have been exposed to COVID-19, and we're trying our best to maintain access to care for all of those in our community not afflicted with COVID-19. Before getting into the details of our testing at Hennepin, I want to make several points clear. First, the most effective strategy that we know of to reduce the transmission of COVID-19 infection is social distancing, period. Second, the ability to social distance is in fact a privilege. Many Minnesotans are fortunate enough to be able to care for themselves, work from home, and live in low-density neighborhoods, all things that are amenable to social distancing. Other Minnesotans, however, don't share this privilege and are unable to effectively social distance. Examples include those working on the COVID front line, such as physicians, nurses, and healthcare workers, community and public health workforces, and all first responders, the elderly and disabled in congregate living facilities, populations with low socioeconomic status living in high-density neighborhoods, and people experiencing homelessness living in shelters. Third, the health outcome disparities associated with COVID-19 are real. In Chicago, nearly 70% of COVID deaths are Black individuals, and yet Blacks make up only 30% of the population. And most of these deaths are concentrated in 5 neighborhoods. Similar disparities have been observed in Louisiana, Michigan, and New York City. An op-ed published in the Journal of American Medical Association last week summed this up by stating the following: even though the data is preliminary, the pattern is irrefutable. Underrepresented minorities are developing COVID-19 infection more frequently and dying disproportionately. So how does testing fit into these points? Let me give you an example. Recently, there was a cluster of COVID cases in a homeless shelter in Boston. In response to the outbreak, the Boston Healthcare for the Homeless conducted PCR testing, the same type of testing we offer at Hennepin, to all guests residing at the shelter over a 2-day period. 36% of the residents tested positive, many of whom were not experiencing any symptoms whatsoever. Available PCR testing here provided the opportunity for early intervention to prevent further exponential spread. These findings highlight how rapidly COVID can spread in a population unable to social distance, and suggest that more widespread PCR testing strategy with rapid turnaround times can assist greatly in identifying and mitigating COVID-19 among patients living in high-density areas. To drive home the point here, more PCR testing availability can lead to more robust mitigation of COVID-19 among populations who do not have the privilege of being able to social distance. So we at Hennepin appreciate this relationship between the availability of COVID testing and health equity, and as a result, we extend our sincerest appreciation to the legislature for your investments in the Minnesota Department of Health that have been distributed to hospitals for our immediate needs. We were awarded $3.8 million for our molecular lab for the purpose of expanding COVID PCR testing statewide, and we've done exactly that. We're fortunate to have the lab expertise on-site at Hennepin led by Dr. Glenn Hansen and Dr. Brad Lindsay that has allowed us to leverage this investment to rapidly scale up molecular testing in a safe, effective, and reliable manner. Thanks to your help, we've been able to acquire the instruments and materials needed to have capacity to process up to 1,000 COVID PCR tests per day and up to 7,000 per week. In addition to testing our own patients, we're currently processing tests for all affiliates of Hennepin County, including Healthcare for the Homeless clinics, Hennepin County Public Health, Jail and Corrections. We're also processing tests for multiple health systems in the Twin Cities area and greater Minnesota, including the Veterans Administration and the Indian Health Board. Once specimens are received, we can offer a turnaround time of less than 24 hours. This rapid turnaround time is crucial. It assists with conservation of PPE in acute care settings, deciding when valuable healthcare workers can return to work, and perhaps most notably, with identifying the most appropriate temporary housing situation for Minnesotans in congregate settings such as homeless shelters and nursing homes. We're currently testing all high priority Minnesotans identified by the MDH list of priority groups, and we will continue processing the tests for external symptoms and providers from all around the state as well. Additionally, we are in the process of expanding specimen collection to several of our neighborhood clinics in Hennepin County. Serology testing, the type of testing featured in Senate File 4500 and that you've heard a lot about already today, can add value beyond the PCR test in the effort to keep Minnesota as healthy as possible. Let me give you another example. In addition to my administrative duties as Chief Medical Officer, I've had the privilege since 2012 to proudly state that I'm an active member of the Hennepin Healthcare medical staff. I'm an internal medicine physician and I provide direct care to hospitalized patients at HCMC. On any given clinical shift, I routinely come in close contact with patients and fellow healthcare workers. Much like my fellow Minnesotans currently residing in congregate living in homeless shelters, I'm unable to fully social distance at work, and therefore I'm more likely to be exposed to COVID-19. This is particularly noteworthy given the degree of asymptomatic shedding of the virus from people who don't know they're infected. Many of those infected may never have symptoms, but the COVID-19 they potentially pass on to others can still be deadly. Serology testing has the capability to better inform those of us who have been exposed in the past to COVID-19. We're still learning about what the likelihood is that exposure will lead to immune protection from future exposure. This knowledge can then help us better understand risk to healthcare workers and evaluate interventions to reduce transmission of disease in the healthcare settings or other areas unable to social distance. As an example of this, we at Hennepin Healthcare will use serology testing to better understand the incidence of COVID-19 in our high-risk clinical environments, leading to important scientific knowledge about how to best protect our workforce. You can use the same methodology to better understand the similar risk to those in congregate settings, and from this develop more robust strategies to mitigate the risk of disease spread in these settings. This has a tremendous potential benefit to keeping our workforce healthy, our underrepresented communities healthy, and our state healthy. We at Hennepin Healthcare are currently validating our in-house serology testing, and soon we'll have the capacity to have results available on an hourly basis during normal business hours for approximately 250 test results per day. Additional investment would allow capacity for our lab to be prepared for larger volumes of testing, up to 1,000 tests per day. This would allow us to not only test our own Hennepin Healthcare employees and patients, but also to provide testing services throughout the state. All of this is in an effort to combat both the COVID-19 pandemic that's impacting us now and the health disparities that have been impacting us for decades. As you probably well know, while Minnesota enjoys some of the better overall health outcomes in the nation, Minnesota is not a leader when it comes to equity and health outcomes. COVID-19 is a reminder that we lack health equity at many levels. Two New York City physicians summed up their observations of the last month in New York City hospitals by stating, "Health equity is not a sideshow during COVID-19, it's the main event." Their experience in New York City indicates that those already living on the margins are most likely to be harmed. With rapid expansion of the availability of rapid turnaround time PCR and serology testing, we in Minnesota have the ability to combat this. Minnesota currently has a window in which the congregate care centers, homeless shelters, and high-density neighborhoods can be most positively impacted by the presence of robust testing deployed in an aggressive asymptomatic surveillance structure. We at Hennepin are pleased to see the legislation in Senate File 4500 designated as a competitive grant. Senate File 4476, however, appears to be narrowly drafted to only be allocated to a national referral laboratory. We would sincerely request that this language narrowing the bill to a national referral laboratory be removed. Non-competitive processes can inadvertently reinforce structural inequities and exacerbate the disproportionate care that we are all committed to addressing to limit increasing disparities among Minnesotans. In summary, I'd like to reemphasize several key points. Social distancing is currently the most effective strategy to reduce COVID-19 infection, period. Populations who don't enjoy the privilege of being easily able to social distance include underrepresented minorities and healthcare workers. For those populations unable to social distance, increased availability of PCR and serology testing can mitigate the impact of COVID-19. particularly if Minnesota moves aggressively towards asymptomatic surveillance testing for these high-risk populations. Hennepin Healthcare can play a leading role in this effort, particularly by satisfying the need for rapid turnaround testing in the Twin Cities area. Non-competitive processes for funding can reinforce inequities and exacerbate disproportionate care. This crisis requires a statewide response, and labs across the state are ready to rise to the challenge. The 7,000 employees of Hennepin Healthcare consider it an honor and a privilege to provide care to many vibrant communities of the Twin Cities area and greater Minnesota. We look forward to continuing to expand our PCR and serology testing capabilities. We're doing this not in an effort to garner headlines or maximize testing profit, but instead we are working to create a testing approach that promotes a healthy Minnesota for all citizens, not just those fortunate enough to be able to social distance. Thank you all again for all you've done to address the needs of healthcare systems so we can do our best to take care of our communities. And thank you for allowing the time to testify today on behalf of Hennepin Healthcare and the community that we serve. Madam Chair.
Thank you, Dr. Hoodie. Have Senator Klein, then Senator Kiffmeyer. Senator Klein.
Oh, well, thank you, Madam Chair. And I think I want to thank my colleague, Dr. Hoodie. I think he's shown the committee why it's such a privilege and an honor to serve with him at Hennepin. And you spoke, all three systems spoke well about how an expansion of testing is going to expand our capacity to control the disease in Minnesota and make us, ahead of the game tactically as we fight COVID-19 going forward. Dr. Hoodie, you added the additional point that a robust testing program will be essential to having equitable outcomes, and I appreciate that. To that end, I think Dr. Hoodie, Hennepin has dedicated their testing to sort of the VA and Hennepin and Allina local systems. I wonder if the other two systems could comment on what proportion of your patients that you're serving and testing right now are going to Minnesota clients and what are going to national or international clients? And can you commit to the committee that you will get Minnesota's needs covered first before we start serving other clients? Thank you, ma'am.
Madam Chair, I can start, if that's okay.
Dr. Toller.
Yes, ma'am. Senator Klein, we know each other from the RDEC. Thank you for everything you do on that, in that capacity as well. The first of everything is the commitment to Minnesota. And as a land-grant university, we absolutely gonna prioritize, everything. I don't even have a plan, to export this anywhere else. This is where we're gonna focus and this is where we're gonna deliver. I have in my vice presidential portfolio, the Cook Clinic, which is, not unlike, Hennepin, 80% immigrant, 90%, people who have English as a second language or a third, like I do. And they are certainly, in the category that need, be very focused and very supported during this, as Senator Hayden and others commented before. Same in the downtown St. Paul. We take it very seriously that we have a network of primary care clinics that do serve everyone and in the state, in the metro, in the greater Minnesota. Madam Chair.
Thank you, Dr. Toller. And if there's someone from the Mayo Clinic who'd like to comment, but I just want to be clear. My goal, the outcome for whatever testing strategy we have, is that it's a partnership that's focused on outcomes for Minnesota. And I know that Mayo has stepped up to be part of that conversation. And so I think if that's our watchword for where resources and language move, I think we're going to have a good outcome. I see Dr. Maurice is unmuted.
Yes.
Proceed.
Thank you, Madam Chairman, and Senator Klein, thanks for the question. We have, since the inception, really prioritized our testing capacity first for the needs of the state of Minnesota, then for our existing partners, and then others who might need access to it. That's been our approach since day one, and it will continue to be our approach. And we have also, on a very personal level, in the early days, I received a very very touching plea from someone from a tribal community that reached out to me specifically because of the concerns about getting testing in his community. I know Hennepin County does this as well, but we have provided some access to the tribal nations at no cost to get testing to them. I would very much like Mayo to do whatever it can to be part of a statewide effort to make sure we reach into these communities, recognizing that testing does need to be available to the hospitals like Hennepin that already have existing relationships. So this should really be how we build something that best serves the needs of the state. And from a Mayo perspective, we've focused our priorities to do whatever we can to be part of that solution.
Thank you. Senator Klein, anything further? Okay, thank you. Senator Kiffmeyer.
Thank you, Madam Chair. I appreciate Dr. Hoodie's comments. I think it is a commitment that we all share, that we want to make sure that every part of the state of Minnesota, no matter their circumstances or situation, have equitable treatment in regards to this. And I appreciate the perspective, Dr. Hoodie, that you bring, and consider that very valuable, and understand your concerns, which are valid. Hennepin is also a very, very excellent resource to our state. A question I have for you, Dr. Hoodie, in regards to, you mentioned some of the other states as far as their outcomes. I think you mentioned one of them, 60% non-white. I don't know if that was deaths or what it was, but could you reflect on what it is here in Minnesota, though? What are those areas for here in Minnesota?
Dr. Hoodie?
Madam Chair, thank you. And Senator Kiffmeyer, to clarify, are you asking which areas are we seeing outcomes that are inequitable?
Senator Kiffmeyer?
No, thank you, Madam Chair. Let me clarify that. There are statewide statistics on the racial makeup of those who have died from COVID or COVID related. And I'm just wondering if you know what the percent is there of non-whites that are passing away from COVID, or the percentage of whites. I follow some of the MDH stuff. Maybe the gentleman from MDH, Mr. Huff, could answer that better.
And Senator Kiffmeyer, would you like to wait for Mr. Huff to speak, or do you want Dr. Hoodie to speak from his understanding?
Well, thank you, Madam Chair. If Dr. Hoodie knows, then I would prefer that he have the opportunity to respond. If not, I'll wait for Dr. Huff or Mr. Huff.
Dr. Hoodie?
Madam Chair, thank you. Senator Kiffmeyer, I'll defer to Dr. Huff on this one.
Thank you. And then Senator Nelson to Dr. Hoodie.
Thank you, Madam Chair. Actually, my question actually was to to all three institutions. One of the things we talked about was the need for testing and to do so at a rapid pace. And I wanted to know, I think Dr. Hoodie said that Hennepin was testing 1,000 a day. Anyway, I'm wondering if I could just hear what those numbers are today. What's the capacity today at Hennepin, at Mayo, and at the U for tests per day?
Dr. Hoodie, if you could tell us what is your testing capacity currently?
Madam Chair, thank you. Senator Nelson, our current PCR testing capacity is up to 1,000 per day.
And in the serologic testing?
In the serologic testing, we're standing up now, but we could, with the existing resources, do 250 per day and up to 1,000 per day with additional resources.
Thank you.
And then the U?
Madam Chair, Senator Nelson, we at the moment, we can do several thousands of each. The capacity, and especially, as Senator Benson, you and others, have made very obvious, and I hope I did as well. This is a collaboration between the university and Mayo, and in that aspect, we are looking at about 20,000 PCRs, which is the molecular, about 15,000 of the serology. This is a large bandwidth. This is a robust, something that will help quite a bit. Madam Chair.
Thank you. That was the comment to Mayo too, and perhaps if one of them, Dr. Maurice, could you answer that question?
Sure. Dr. Bineker, if he's still on, he can give you the real time. But currently, for the Rochester practice, we have about 5,600, 5,700 PCR tests available today. 20,000 with capacity to do 20,000 serologic tests today. But Mayo Clinic Labs does have testing capability in Florida as well. So the whole of Mayo Clinic right now stands at about 7,500 PCR tests per day.
Thank you. Thank you. Thank you, Madam Chair.
And thank you to all the physicians. You all have such critical things to do. I appreciate your willingness to stay present for the committee questions, but understand if you need to move on to other work. I know you have great people working for you who will help us to access more information if we need it. We're going to move on to Daniel Huff from the Minnesota Department of Health to talk about what the statewide testing could look like. This is not final, but wanted to start a framework for this committee. So Mr. Huff, I understand you have some slides you wanted to share.
Yes, Madam Chair, thank you. My name is Daniel Huff. I'm the Assistant Commissioner for Health Protection at Minnesota Department of Health. And I'd give a kind of an overview, just generally framing the different testing options and how we're viewing that from the Minnesota Department of Health and what our overall strategy is for testing in Minnesota. To that end, I am going to work to share my screen with you. Is that working there?
Yes.
Yeah.
Thank you.
All right. So first of all, I just wanted to, we heard a lot today about different types of tests. We have molecular or PCR test, and then the serologic or serology tests that look at antibodies. So I thought I would just kind of go through a little bit and talk about what these different types of tests are. First, we have our molecular tests, also called the PCR tests. These are actually the diagnostic tests that we use to say, hey, is someone actually infected with the virus? Now, the virus is SARS-CoV-2. That's the name of the virus that causes COVID-19. And the way these molecular tests work is they actually detect a viral RNA. The accuracy of these tests are, while the laboratory part is fairly accurate, if there's RNA found, there's RNA there, that means the virus is present. However, you can get false negatives depending on how well the sample was taken and what's the viral load of the individual at the time that the sample was taken. So depending on how sick you are, how much virus you have in your body, and then how well those swabs are basically, they stick it up your nose and down your throat. It's not a very comfortable thing. But how much material's got off of that as to whether you have an accurate test or not. So some studies have shown that you can have false negatives as high as 30%, depending on how well the sample was taken. These are always performed at a certified lab. We do them here at the Department of Health Public Health Laboratory. We were the first lab to start doing these as soon as the CDC made them available for the states. And then the next kind of test are these antibody tests. These are the serologic tests. So they indicate that you've had an immune response to an infection because you have now developed those antibodies. And it may take many days after the infection. Some studies by Mayo shows that after 14 days, there's usually enough antibodies that they get very high success and accuracy in their test. But anytime less than that, it may not be able to detect accurately that antibodies have been formed. Now, there's a lot of these on the market. And while we have some really high quality tests being developed in the States, such as at the university or at Mayo Clinic, there are a lot out there in the market that are not just specific to SARS-CoV-2. So there are human coronaviruses that circulate. These are the what cause some of our common colds. So some of the lower quality tests will actually show that you've had one of these common cold type coronaviruses. So it's very important that people know that these are not, that not all serology tests are the same. This is a blood test, and these are also performed in a certified lab. They may be collected somewhere else, but they are performed in a certified lab as well. And there are a lot of, unfortunately, fraudulent tests out there just because of the proliferation of this type of test. Okay, and then if we look at the uses of these tests, molecular, it's to detect if someone has the disease. From a public health perspective, when we find that someone is infected, we isolate that person and then interview them about any contacts, and their close contacts are quarantined. It's very important as we look to protect our vulnerable populations, for example, in congregate care settings. It also helps with surveillance to detect the prevalence, how much disease is out there, and also the rate, how quickly people are getting infected. Serologic tests, and I think I appreciate what Dr. Benneker said about how there's a lot more to learn about this disease and this virus. We may infer that there's protective immunity, but we don't know for sure, and we don't know how long that will last. And I think that's important. Some people think, well, if I get a positive antibody test, then I have a get out of jail free card, and I don't have to social distance anymore. I don't have to do any of these things. And that can be actually quite harmful if that person is still infected, or if they get reinfected and then infect others. But it is good to look at what we call seroprevalence, which is how many people do we think have been infected, so that it may indicate when we're going to have some degree of herd immunity. It's important to know that this is not for diagnosing if someone is positive with COVID. So our testing strategy in Minnesota, our goal is to dramatically ramp up testing for the following. One, we want to test all symptomatic people. Anyone in Minnesota that has symptoms, we want them to be able to go to their clinic, go to their health provider, and get tested. We also want to focus testing in our vulnerable populations, our congregate care settings. Right now, a large proportion of our deaths and fatalities are people that are in long-term care settings. This is testing. This is one way that testing can help us protect people, is to prevent it from entering these settings, and when it does, making sure we're effectively isolating people. We also want to protect the staff that are serving these vulnerable populations. Staffing is very, very critical, especially at a time like this. So people who are serving people experiencing homelessness or long-term care settings, we want to make sure that those people are safe and can go back to work, as well as protecting our healthcare workers and first responders. We want to make sure that we focus testing on communities of color. I think Dr. Moody referenced the fact that we do have concerns in other states about how communities of color may have been undersampled. And so we want to make sure that all communities are having access to testing, and especially any communities that may be dealing with existing health disparities. Also, Senator Benson mentioned this, making sure that we are testing the workforce of our critical infrastructure, grocery store workers, utility workers, transportation workers. Without these folks, we could not continue to function. Our infrastructure would seize up, and so we need to test these folks as well. a very important public health goal is by doing broad scale testing, we can do isolation and quarantine of folks to slow the spread of the virus. That's a very important public health goal. It also helps us with that increased surveillance. And I'm going to talk a little bit more about what that gives us. Right now, prioritized molecular testing is based upon these priorities. This is what MDH has prioritized if testing is limited. We are rapidly expanding capacity in Minnesota right now. Mayo has the capacity to do thousands of tests. As we heard, Hennepin Healthcare has the capacity to do 1,000 tests a day. Mayo, I think, is several thousand, maybe 5,000 a day. So we do have testing capacity in Minnesota, and that's why we want to open it up to all people who have symptoms and focusing on these vulnerable and prioritized populations. Okay, so when I talk about surveillance, and Dr. Tolar mentioned my analogy of the truck going down the hill. So let's picture we're in a truck, we're at the top of a mountain, and we have to get down that mountain. That's when we are on the other side of this virus. When we have enough herd immunity that we don't have to worry about it anymore. We're at the top of this mountain, and if we get going too fast, we may go off the edge. There's no guardrails here, and if we go off the edge, what that means is we crash our healthcare system. We have so many people who get hospitalized and in intensive care to where we end up with situations like they have in Spain and even in New York City, where physicians are actually choosing which patient gets the ventilator, knowing that the other patient will die. We do not want to have that in Minnesota. We don't want our healthcare providers to have to face that decision, and we don't want our loved ones in Minnesota having to know that they may die because we had to ration necessary medical equipment. So it's really important we don't get going too fast down this hill. We are somewhere in the early phase. We are lucky in Minnesota is that we have the lowest rate of lowest prevalence of the disease of any state right now. And I think that is a testament to the strong leadership that we have from you, your colleagues in the House, and Governor Walz, and the fact that we as Minnesotans really do stick together in order to protect each other. Here is how testing can help us as we go down this hill. I like to say we're going down the hill in the dark with no headlights. Testing gives us headlights. As we go down the hill, the molecular tests give us two things. They give us the idea of how far, they give us how fast we're going down the hill. They give us the rate. As that rate increases, we need to do something to slow down, to press the brakes. One of the tricky things about this virus, because it can take about 5 days or so before someone has symptoms or someone is infected until they actually get symptoms. And then it may take them another week or two before they have symptoms that are severe enough where they would have to go and get help from the doctor. So if you think about, in the wintertime, we have to increase our following distance because when you press the brakes, it takes you longer to stop because you're skidding. Think of it here, going down this mountain, it's going to take about 2 weeks from the time we press the brakes, 2 to 3 weeks until we will see a slow in the rate. If you look at what's happened in New York City and Italy, when they did really strict stay-at-home measures, it took 4 weeks for it to show back up in their ICU capacity. So it could be up to a 4-week break time of when we put the brakes on through community mitigation or other social distancing measures as to when we slow down enough if we've started to go off that cliff. The other part of this is the serologic test. This tells us how far we are down the mountain and how close to herd immunity. So think of the serologic test as how many people have been infected, which is the more people that have had it, the farther we are down the mountain. These slides just give you an idea of how many tests we've been conducting in Minnesota. As I said, we have the capacity to do several thousand, upwards of over 5,000 a day in Minnesota, but we are not testing that many people. That's why we're looking at expanding our guidance to healthcare to test more people. And we are working with all of our partners, both the U and Mayo, as well as folks like Hennepin Healthcare and all of our major health systems to increase testing and make sure that the lab capacity is there to meet their demand. Now, this is a couple weeks old now, but you'll see that our cumulative test per 10,000 in Minnesota is fairly low. We're only 32nd, and that's something we want to increase because we don't know what we don't know. And while we've done a good job, we have a low positivity rate that is slowly increasing, and we want to get out there and do more testing so that we make sure that we slow that virus down. Here is additional information on the NDH website about the disease testing. Now, I'm going to try to share, if I can, for Senator Kiffmeyer's question, or Senator mentioned I will wait. But if you'd like, I could answer Senator Kiffmeyer's early question.
Thank you, Mr. Huff. And if you want to answer Senator Kiffmeyer's question, I would appreciate that.
Great. Okay, so this is from our website that we're updating every day. And this gives you an idea. Am I still sharing? Is this working?
I'm not seeing a change on your screen. I'm seeing your additional information slide.
How's that?
Thank you.
All right. Getting the hang of this. So this is from our website. So you can see both our percentage of cases and our percentage of deaths. While we do have a majority of our cases are white individuals, it's disproportionate to the number of white people in the state. So we do see disparities here in that we have a higher rate of cases in people of color, communities of color, than we have just based upon their numbers in the population alone. We don't know if we have undersampling or not. We have not been able to get testing data or demographic data for testing yet, but that's something we're working on. But this is from our website updated today, Senator Kiffmeyer. And with that concludes my presentation, Madam Chair, and I'm available for any questions.
Thank you, members. And I'm not seeing hands raised yet, but if you have questions, please raise your hand for Mr. Huff. And then we do have Mr. Bentley Graves from the chamber. And as we try to safely open business, I think it's important that we have time to hear from him, and then we'll have Senator Nelson. So I see Senator Kiffmeyer with your hand raised. Please proceed, Senator.
Yeah, thank you. But I think considering the shortage of time, I'd rather get on so that we hear from the chamber before I ask my question.
Okay, thank you. Let's proceed to Mr. Bentley Graves. I'm grateful to have your voice added to the reasons we need to have testing, a coordinated testing strategy in the state of Minnesota. Welcome to the committee.
Thank you, Madam Chair and members. Thank you so much for the opportunity to add our voice to the conversation today. Certainly, I can't add nearly the detail and information that was provided by the medical professionals, but just want to add our perspective from the state's business committee about our view about the importance of testing, in particular ramping up testing, and very appreciative to hear from all the institutions about their ability to ramp that up, their capacity. And also to hear from Mr. Huff about the department's willingness and interest in active engagement in changing the guidance around testing and making the testing available to more. Throughout this pandemic, the goal of the chamber has been to help strike a balance between safeguarding health and protecting Minnesota's economy. We believe that increasingly, businesses are ready to reopen. Certainly, there are a number that have been open. Those that have been deemed essential have developed detailed strategies to protect their workforce from the spread of COVID-19 while ensuring continuity of operations. we just today released guidance based upon input from our members, based upon federal guidelines about how businesses who are either essential and are operating can redouble their efforts to keep their employees and their customers safe, or to give guidance to those businesses that have been closed, give them guidance about how to prepare to reopen. And importantly, what we've also heard is those businesses that are closed have not been sitting idly by these past many weeks that they've been closed. They have been diligently working on plans to bring themselves back into the economy safely, bring their employees back, and keep their employees and their customers safe. But a key component of this will be the testing capacity in the public health infrastructure to keep their employees safe, to support businesses. We heard today just another reminder about how fortunate we are in Minnesota to have the healthcare infrastructure we do in this state, from the University of Minnesota to Mayo to Hennepin Health. We know that there are many, many others who have led the response to the pandemic, worldwide out of Minnesota. And that expertise and that readiness here in Minnesota positions us well to lead the nation in bringing businesses back and reopening our economy. But again, critical to that is going to be testing infrastructure, public health infrastructure with contact tracing and isolation to support these businesses and their employees as they carefully, responsibly, safely return to work. So we want to thank Senator Benson for the legislation she's brought forward to begin to make those state investments to ramp up testing. We want to thank the Walz administration for putting a priority on this, recognizing the importance of testing as a tool to take the next steps. And we just want to add our support and our voice to those efforts within the legislation and administration to find the resources to make those investments in testing in the public health infrastructure to move us forward, and to thank all those that are involved in the effort to do so, whether that's those folks participating in the hearing today or others. Again, this is a critical piece of returning, our state to the economic vibrancy that is a hallmark of Minnesota. And we look forward to working with all of you in the days and weeks ahead to make sure that infrastructure is in place. So thank you again, Madam Chair, for the opportunity to share that with you today. Happy to answer other questions, but certainly want to keep it brief in respect of the time. So thank you.
And I want to thank you, Mr. Graves. I was on a call earlier, and I think Senator Rosen, I can't remember who else was on the call, with Sanford Health. And when JBS needed testing, there was a partner healthcare system who could step up and prioritize that critical food infrastructure. And I hope that becomes the pattern that we see. Working with MDH, we're going to have a few care systems that we're going to lean on a little bit more as we build this partnership to meet the needs, yes, of those critical populations, but then as the business community needs support, as employers are doing their very best to open in a safe way, that the experts, some of whom were on this call, others who are behind the scenes, could help craft thoughtful plans and be good partners. And so I'm grateful that you were here today, so that as we get ready to open up the economy, we have clear communication and partnership. With that, I see Senator Kiffmeyer's hand was up. I don't know if it's for Mr. Graves or for MDH. Senator Kiffmeyer.
Thank you, Madam Chair. I appreciate Mr. Graves' comments, but my question is more for Mr. Huff. And in particular, we've heard wonderful things from Hennepin, from HCMC, from Mayo, from the University of Minnesota, now Sanford as well. Great to hear all of that. But the big thing is, how do we get to the large-scale testing? How do we make sure it's coordinated so that all are covered in a fair and equitable kind of a way? And the federal and state dollars, a variety of things like this, that those things are paid for, which are funds that come from the taxpayers. So this is more of a how do we get there? And maybe that's a question for another committee hearing, another issue, Madam Chair. That's a logical next step. That's all my comment, Madam Chair. Thank
Very
you.
good. And Senator Kiffmeyer will leave that as a comment because it is my hope that we'll have language before this committee that's very specific and a little more clear. Senator Abler, I see that you've gone off mute. Do you have a question?
I do, yeah, and I don't know how to find the hand button on here. I don't have any teenagers left at home. Just a short one for is it Dr. Huff? He had mentioned that we're doing something between 1,000 and 2,000 tests a day. We could do 5, and we need to tell people to ask for more or something. Some people have asked me, why can't they get a test? So how do we go from what, it seems like everybody wants more tests. So can you just tell me what the snag is on spending all those 5,000 tests? Thank you.
Mr. Huff?
Madam Chair, Senator Abler, I'll send you my teenagers if you'll keep them for the next till schools reopen. It's a great question. So if I want to get tested, why can't I? And that's what we're trying to solve. What we have is that there are shortages in different systems. So while, say, Hennepin Health Care and Mayo have really a lot of capacity, we have other systems that have much more limited capacity. And this is based upon a lack of reagents. It's based upon really supply chain issues. We are fortunate to have great laboratorians in this state who have been working in all of our different healthcare systems to build up lab capacity internally. What our strategy is from a statewide perspective is, how do we build this capacity statewide so that we build so that we have Essentia Health have more capacity up in Duluth at the same time that we have overflow capacity, say at Mayo or at the U, Hennepin Health, where people can send their tests if they have more people needing testing than they can do in-house. That gets to what Senator Kiffmeyer was saying, is we need to have a coordinated strategy on this, and that's what we're working on. How do we make sure that regardless of what your healthcare provider is, you are able to get testing, regardless of your socioeconomic status, you're able to get testing, so that we are working closely with the CEOs of the major healthcare systems, with Mayo, with the U, to work on how do we do this? How do we make sure that we have sort of a centralized lab capacity at the same time that we are building capacity at each individual site? But right now, I would say call your doctor, We know that right now, a lot of your ability to get tested depends on which healthcare provider you have. And that's not what we want in Minnesota. We want every minute.
And Madam Chair, just briefly again.
Thank you, Senator Abler.
Well, it seems like it's just a matter of logistics, and the governor has taken some very strong productive actions toward this, and this is his number one thing. So I mean, beyond this, I'll leave it rhetorical, but I don't know why everybody's not cooperating to make sure who seems to need them gets them, independent of what plan you're in. So I guess that's an editorial thought, that it seems like that would be easy to fix, since that's the number one thing we need is 5,000 a day. And thank you very much for the information.
Thank you, Senator Abler. I'll count that as rhetorical. I'm going to move on. Senator Hayden, I see your hand up, and then Senator Johnson.
Thank you, Madam Chair. And Mr. Huff, I don't know if you can answer this question, but in other states, there has been this outbreak in correctional facilities, either local jails, county jails, and maybe even prison. I've just been hearing a lot about it. I haven't heard the latest at Hennepin. I know that they were trying to figure out the testing protocols, I guess would say. So do you know, and if you don't, I don't know if there's someone else that knows and understands how we're testing in correctional facilities, via those be county jails or the Department of Corrections.
Mr. Huff?
Madam Chair, Senator Hayden, we are working closely with the Department of Corrections to make sure that folks that have symptoms, either they be the staff working there or the inmates themselves, get tested. It's as a congregate setting. It is a very high priority for us at the agency at MDH that we make sure that anyone, either our officers, our guards, or the inmates themselves, are tested and then isolated so that we don't infect other members of the population.
Okay, thank you. And Senator Jensen, if we could briefly have your question, then we're going to have 5 minutes for Senator Nelson to present her bill. So, Senator Jensen.
Thank you, Madam Chair. And I always love it when you say briefly in front of my name. Some people think I'm Dr. Briefly Jensen. Anyway, Mr. Huff, can you understand the frustration of the Minnesota people? I mean, we've provided over $500 million of support for the COVID-19, and we've heard over and over again, especially the last 10 days, testing. We're told that it's available, we could be doing it, but it doesn't seem like the Department of Health has been able to succeed in being a centralized place. You said call the doctors. Well, frankly, I'm a doctor, and I've had patients call me, and I just throw up my hands and say, I don't know what to tell you, because we're not getting any information at all. I don't happen to belong to a big system like Allina or Health Partners, but the bottom line is there is no place that I can tell someone to go for a test in Carver County without them having to go through an emergency room or an urgent care center, which generally gets them to $1,000 bill. I mean, it's just frustrating as all hell that here we sit and everybody says testing, and PPE. And it sounds like we have it within our grasp to solve this problem. I mean, we should be having someone in your department working 24/7 to get this set up so that we can get a notice to every doctor in the state of Minnesota. Here's how you do it. Can you help us?
Mr. Duff, or Huff, sorry.
Senator, or Madam Chair, and then Senator Jensen, I sense your frustration. I'm frustrated too. And the fact is, it's the healthcare systems that decide how they do testing. We at MDH provide guidance. I share that guidance in one of my slides. And we know that some healthcare systems are not even testing everyone on our guidance. And that is what we are working on, is getting every healthcare system to follow our guidance. And we want to move towards every person that has symptoms is able to get tested. But I definitely agree with your frustration. It is frustrating because we at MDH want every person that has symptoms to be able to get tested. And we are working at it on all sides or all parts within the system. We've had some bottlenecks on equipment such as swabs and reagents, and we're working on that. We have a full-time person whose job is helping with purchasing for our hospitals and our laboratories. And we have a work group. Some of the folks that presented today are on that work group of how do we coordinate among all of our healthcare systems. It is, as you know, healthcare is complicated. And sometimes it feels like you're pushing a wet spaghetti noodle. But I definitely agree with your frustration. And we do hope to have a more overarching solution shortly.
Thank you. And if I could go to Senator Rosen, we're well past our time, and I want Senator Nelson to have some time. We'll have more testing language before us, Senator Jensen. Senator Rosen.
Well, thank you, Madam Chair. And perhaps I should have asked this question before, and it could be answered in our next series or your next committee. But Dr. Huff, I know that Mayo has, of course, their testing, and that they will be taking that outside of Minnesota. Is that correct? And they will be charging for that testing. Is that correct? And my other question is University of Minnesota going to be offering their testing outside of the state also? And will they also be charging for that testing? I'm not sure if you're the right one to answer that, and I probably should have brought this up earlier, but need to know the economic parameters on all these testings and who is going to be benefiting from the revenue that's coming in if they are going to be selling their services and their testing outside of Minnesota.
Mr. Huff, if you would like to defer, and I don't mean to be disrespectful, Senator Rosen, the finances of the statewide testing haven't been architected, but I think we can all agree that if it's Minnesota dollars, it needs to be Minnesota priorities, but perhaps Mr. Huff has more than just an opinion to add.
Madam Chair, Senator Rosen, Mayo is a national reference lab, so that means they have customers from all over the country, and they have customers from inside of Minnesota. All labs charge for their tests except for the public health lab, but all labs charge for their tests. You'll see it on your insurance bill or your clinic bill, and Mayo is no exception. What we are working on, any agreement that we have with state dollars, the test has to be for Minnesotans. So Dr. Hootie mentioned grant money that we dispensed through the first amount that you appropriated to MDH, which allowed them to stand up testing at Hennepin Health. And that is definitely for Minnesota residents.
Madam Chair.
Senator Rosen?
Thank you, Madam Chair. I would, and please indulge me at some point to drill down on this issue more. I know we're out of time, and I would like to have more clarity on the specifics of how is Minnesota and our testing going to be handled, and the issue of commerce outside of Minnesota and the testing, especially if there's state dollars involved, that we're giving both of those institutions. I think that we deserve an answer in that realm.
Absolutely. I agree.
Thank you.
I agree, Senator Rosen. Members, that'll be the end of our questions. I'm going to ask Senator Nelson to briefly present Senate File 4475, and that will be placed on the table. Senator Nelson.
Thank you, Madam Chair. Actually, it's Senate File 4476, and I want to thank you, Madam Chair, for your leadership on our COVID-19 response and for making Senate File 4476 part of today's hearing. Well, today's hearing did demonstrate that the best way to get people back to work and school safely and quickly is testing, and we've talked about that. We can't have an economic recovery, much less a fast one, without widespread testing, and it will, I believe this will bolster our economy and improve forecasts more than any other investment. Testing is a good return on investment for the state, and that's why I wrote Senate File 4476. Briefly, it's a $20 million grant to advance research, development, and implementation of tests necessary to respond to the COVID-19 pandemic. The $20 million is an appropriation, one-time appropriation to the Commissioner of Health to award as a grant for that purpose. I think these following pieces will answer some of the questions those good questions that were brought up today. To be an eligible applicant, it must be a Minnesota-based clinical research institution. It must be a national referral center. It must be engaged in providing patient care, medical research, medical education. And then to your point, what should those grant dollars be used for? According to this legislation, they must be used to develop, to research, develop, and implement the SARS-2 COVID-2 testing, including, but not limited to the following: rapid response testing, quantitative droplet digital diagnostic testing, serologic and neutralizing antibody testing, viral antigen testing with mass spectrometry, immune response and stratification testing, and then SARS-CoV-2 point of care testing, and the same for tissue testing, and then the next generation of sequencing of COVID-19. The eligible grantee must have the ability, I think this gets to the effectiveness, must have the ability to establish a team of clinicians, pathologists, clinical laboratory specialists, business development professionals who then must be able to interact with experts in infectious diseases, virology, microbiology, and research in other clinical laboratories to do the following things: to provide the most efficient response through research, development, and implementation of the SARS-CoV-2 tests that are necessary to diagnose and effectively treat patients, to identify individuals who may be able to return to work, and to aid in the development of a usable vaccine. The grantee must agree to do the following: to provide priority testing of tests received from Minnesota providers. There must be free testing and support to all tribal nations within Minnesota. There must be support statewide access to serologic testing as the testing becomes available. Of course, I put in some safeguards in there as well. Obviously, the commissioner would recover any dollars that were not used properly, and there's no double dipping. The total amount received from the non-state sources cannot exceed the cost of the research, development, and implementation of the testing. And I would just end saying that time matters. The longer we wait, the harder it will be to capture the impacts of testing. And also, we must remember that as other states and organizations move to capture testing capacity, supplies are going to be in short supply. Waiting, I fear, will put Minnesota at a disadvantage to get what it needs to deploy testing rapidly. As you have heard today, Minnesota has the resources and the organizations for the best in the class testing effort. I would humbly request that it's time that we act on this now. And just to close, we are very fortunate to live in a state that is known for its innovation, high quality medical innovation research. And so thank you, Madam Chair, for the time. And how would you like, what is the motion you would like this to be laid on the table?
We're going to table the bill, Senator Nelson, so
Okay.
that it doesn't move without the committee being aware of it.
Thank you. Senate
So-
File 4476 is laid on the table.
Thank you. And members, I do have some hands raised. If you want to unmute yourself to let me know that you still want to ask a question. I have Senator Kiffmeyer. Okay, and now Senator Klein jumped in. So let me do Kiffmeyer, Hayden, Rosen, Klein. No.
Thank you, Madam Chair. I appreciate this bill. I do think, though, that there needs to be more input into the end result, which is the quantity of testing, and using this money more for the actual tests and getting that out there. I think the science, a lot of these other things have already been done. What we need is the results of that in actual testing. I'm not confident right now with the description that I've been able to read in the bill and such, that it is focused enough in regards to that effort and also the coordination that it takes statewide. Just a comment for now.
Okay, thank you, Senator Kiffmeyer. Senator Hayden.
Good. Well, thank you. Oh, hold on. Did I come off? Oh, yeah, I came off mute.
You're good.
So thank you, Madam Chair, and to Senator Nelson. I noticed you have a lot of qualifications on who could get the grant. In particular, on line 1.13, it says a Minnesota-based clinical research institution that's a national referral center. Offhand, Madam Chair or Senator Nelson, do we know how many Minnesota-based national research centers we have?
Senator Nelson? You'll need to unmute yourself, Senator Nelson.
Excuse me. Yes. Thank you, Madam Chair. Senator Hayden, I do not know how many nationally, I forgot the exact term, or national referral centers we have. However, I would say that we clearly want to make sure that we are investing our resources in a nationally recognized testing, nationally recognized research. You might have heard recently about some of the tests that were they were inaccurate, and there were some tests, there was some faulty testing, and it would not serve Minnesotans at all well if we invested in anything other than the high class, high bar testing and that our state has come to expect. Now, someone may have a more clear answer, Senator Hayden, but my point is to make sure that the dollars we invest get the results that we need, which are tests that are accurate, and then to Senator Kiffmeyer's point, really get to that capacity range as well, which I think we heard today is 20,000 a day.
And we're going to go briefly back to Senator Hayden, then Senator Klein, and then we're going to wrap up, members.
Well, thank you, Madam Chair. And I would ask Mr. Huff that question, but here's what I think is happening. And I don't want to, it appears that the Mayo Clinic, I know by their testimony, is a national referral. I want to read it right. A national referral center. It sounds like we have other systems that are doing good work. We talked about HCMC and the plethora of patients that they have. So when we get to the more depth of this and we have more time, I'd surely like to know if there are more. So it appears that this might be narrowly written for the Mayo Clinic, and I have all the utmost respect for them, but I'd certainly like to get more advice from people a little smarter than me if there are other labs and other systems that could also do this work and to make sure that they have an opportunity as well.
Thank you, Senator Hayden. Senator Klein. Senator Klein.
Thank you, Chair. And Senator Hayden actually just made my point, which is that this does seem to be a bill that might be tailored to one organization in Minnesota, which is probably not a good tactical strategy and maybe not good legislating either. And I guess I would also just follow that up with any money we give to any organization in Minnesota for testing needs to come with sort of a promissory note or some sort of agreement that testing is going to prioritize Minnesota citizens and not, national or international clients. So thank you, Madam Chair, and it's not a question.
Thank you, members. And with that, I just want to remind you, I'm placing Senate File 4500 on the table. My mission for any language that comes out of this committee is that it would be collaborative. House, Senate, Governor, the care systems that provide us good quality information as they have in these hearings and good quality testing to the people of Minnesota, that there would be access across communities. We heard that a number of times. Rural communities, communities of color, the business community added their voice because opening up businesses is something that all of us are interested in, that the language would support sound clinical goals so that we understand the SARS-CoV-2 virus and how COVID has impacted and may impact the citizens of Minnesota. We want to protect our healthcare workers, protect the vulnerable, get us safely back to work. We're going to have to talk about funding sources. Senator Rosen, you were right to raise concerns. The governor has federal funds available. He has funds the legislature has put forward. So we're going to need to be clear about funding sources and uses. I also want to raise now, before we close out this hearing, the rights of individuals to not have their testing information shared broadly, that it be used with informed consent and a right to their privacy. So these are all things that I hope when we bring language and all of you get to look at it, that you'll consider some of these things, but also your own perspective. I look forward to bringing language to you in cooperation with the Department of Health and the Office of the Governor and folks in the House and all the care systems who are going to be able to help support our work. So thank you very much,
Madam
members.
Chair,
And
Madam
with
Chair.
that, Senator Nelson, we are adjourning.
So, Madam Chair, just one comment. I believe that perhaps there was some injustice in how this bill was described. And I do want to make sure that this was not designed to be a particular bill with one entity in mind, but it was designed for excellence. And as you heard in the testimony earlier today, Mayo and the U have a long history of working together on many initiatives, including the Genomic Partnership, the Minnesota Partnership, and it was never my intent to undermine any of those relationships. We would expect those kind of things to continue. So the comments are well taken, but I wanted to make sure that there was some clarity there too. Thank you, Madam Chair.
Thank you, Senator Nelson. I apologize for that, members. I was trying to wrap up. I appreciate your patience. We will update you on what we would have available Thursday, but as for now, there's nothing on the agenda. And with that, members, we are adjourned. Thank you for your time today.
you.